who I am. All right. So thank you very much. It's been quite a day. I think it's my privilege as co-chair of the Roundtable on Population Health Improvement to accomplish a couple things at the end of this meeting. One, I want to make some announcements and thank yous. Two, I want to offer some comments in summary, some observations. And three, and most importantly, I want to invite you to the microphones, those of you who are members of both of the roundtables, to make observations on what you've heard today. A good summary by a workshop, in my opinion, includes not only information from very smart people and very motivated, committed people, as we've heard today, but it also includes observation and insight that's generated by that presentation and by the questions. So your job is going to be, while I say a couple things, to think about how you can contribute to the strength of this important workshop report that we're going to create as a result of this by making those observations in a few minutes. So I've given you fair warning. The other thing I'll tell you is if you don't come up and volunteer to do so, I will call upon you. So if that may motivate you to think about it as well late here in the day. So let me first note this has been a very informative and fruitful collaboration between two roundtables of the National Academies. One that I'm co-chair of, the Population Health Improvement Roundtable, and secondly, the Promotion on Health Equity and Elimination of Health Disparities Roundtable. And I, for one, am very grateful for the fact that we've had the opportunity to have that collaboration result in such an effective and important conversation that we've had over the course of the day. In the next few days, video of today's presentations and questions sessions, as well as the PowerPoint presentations that you've seen, will be available on the National Academy's websites. There are several web pages, one for each of the roundtables. And on each of those web pages, I'm told, there will be a link that will take you to a spot on the internet to download those assets and resources. If you're like me, you'll want to refer to them in thinking about what we've said today and reflecting a little after the fact, and use those resources. In addition, we will prepare those workshop proceedings that I mentioned that you're going to contribute to with your astute comments. That will be a product of an independent rapporteur and will be published by the National Academies Press in the coming weeks and months. I would like to, in particular, to give thanks to Karen Anderson, Darla Thompson, Kimani Hamilton-Ray, Anna Martin, and Alana Bechu, staff of the roundtables, as well as Hope Hare, who is Administrative Assistant for the Board on Population Health and Public Health Practice, for their work in bringing this event to fruition. So let's thank the staff. Thank you. I am also extremely grateful for the efforts of the Planning Committee. I won't read off all the names, but planning committees, in terms of the discussions with the staff, the lead up to the preparation and planning for these events, are critically important to the quality of the conversation. So again, thank you, planning staff, planning committee, for helping bring this to fruition. Lastly, a number of you have traveled from long and short distances, local as well as more remote locations, to contribute your wisdom to presentations and the discussion we've had today. So thank you for taking that trouble and for your preparation and for the effectiveness of the conversations today. Thank you. So a couple of comments that I'd like to make. I found this conversation particularly stimulating today. In the keynotes that we looked at early in the day, the Morris and Meat keynotes. The issue of root causes, and Dolores, thank you for that question. You have the best question of the day, in my opinion, because she's asking, what are the upstream, the root causes for some of this disparity, is the way I interpreted your question. You didn't quite say it that way. But I took away from the keynotes, at least, teeing up the issues of poverty, history and culture as reflected in patterns of disparity across the country, and then the deep issue of racism as it's manifest in various areas in history in the country. I think some great insights there in terms of working upstream in terms of those issues for future conversations about exactly how that transpires, exactly its relationship to geography, and exactly that history and culture. As I asked the question at the end of that panel, I'm very much interested in how that history plays out, what we can learn from it, and particularly what we can do about it from those insights. The panel on local philanthropy, the Black Belt conversation, the Appalachia conversation, and the New Mexico example, the inspiration generated by the taking what we have to make what we need kind of comment from the Black Belt conversation. The insight from Appalachia in terms of when government and industry are accountable for human needs without exploitation of people and their health raises an issue which we've barely scratched the surface on in this conversation today, which is what we are not doing in terms of government to protect the people across this country, including in rural areas, in terms of efficient government. And then the New Mexico example, the majority-minority sort of dilemma that was raised there in New Mexico. And then from the Native American conversation that happened on a later panel, from Denise Livingston, who I then went and talked to in the hallway, in terms of good and bad tribal government in terms of local policy. And she mentioned some examples of good tribal government, I believe the Mdewakanton Sioux and Seminole, if I'm getting that correctly. But she also indicated the tension in her own struggle in terms of drawing attention to food and safety issues with the current tribal government that she's working with. I wonder about what it is about government and power that causes disconnect from those impulses of the needs of people in rural communities and on the front lines, everyday people. Not just tribal government, but state government, local government, and federal government. I think there's a lot of interesting opportunity for us to think about the role of government, not politics, but the role of good government and bad government. I know my colleague Tom Kotke in the room in the commentary he wrote for our roundtable on well-being and well-being in all policies, noted the association of good nations in terms of well-being with strong rule of law and human right, low rates of government corruption, efficient, effective government, progressive taxation, and other factors. And I think that when we think about that in terms of regions of this nation, rural and urban areas, I think we need to think about that. So I think there's an opportunity there. This last panel, in terms of thinking about quality of rural health care, my co-chair, Sandy Magden, talked about her rural roots when she introduced the session this morning. I, of course, primary care, internal medicine training, and really pushed forward an ambition that I had after I returned from the U.S. Navy to be a LMD, or a local medical doctor of primary care. LMD was a pejorative phrase that was applied to primary care in my time frame. This is now 45 years old, ago in terms of those who had the ambition to practice primary care and not specialize. I then practiced in northern Illinois in a semi-rural community, farming community, for my clinical practice years, and noticed the difference in quality and perception of quality in terms of rural areas and urban areas. That's a real problem for rural areas, and one that needs to be overcome. We tried to overcome that by bringing university expertise to town, partnerships and so forth, but we never could quite overcome that. And the assets and resources in terms of human resources as well as other resources are very real in rural communities. More recently, I was asked to comment on the Integrated Healthcare Association's Cost and Quality Atlas for California. And when you bring in the social determinants of health along with the distribution of quality across that state that has vast differences in terms of opportunity advantages for very high income areas in Silicon Valley, very high education areas, and very low opportunity areas like Central California or the rural areas, there's tremendous variation in quality. And if you look at by economic opportunity, the variation is the greatest, but you can also look at it by race and ethnicity because they have the data, and there's also a difference there. But for people who have coverage, who have access, who don't have copays and so forth under the current legislation, the variation in preventive care opportunities for detecting colon cancer vary from 85% in those advantaged areas down to 18% for African Americans on Medi-Cal in California. All these people have access to health care, and so the differences are terrific, and they correlate very heavily with education and economic development. So I appreciated the presentation we had on economic opportunity and resilience, but I think we could have gone a lot further. I think we need to think about the expertise that we can gain from economists, but also geographers in terms of thinking about some of the factors that we are not thinking about in terms of our conversation, in terms of why rural health is disadvantaged in this country, why racism has institutional factors and is so embedded in some of the regions of our country. So those are a couple of observations I would make, probably too many observations. But I would tell you that I think the Population Health Roundtable's focus on the 3 E's, equity, economics, and education, is reinforced by this conversation today. I think those are topics that need deeper understanding by us and more conversation. So with that, I'll move to the third task that we have for this summary session. I need you to go to the microphones. I need to make your observations and insights. And those of you who want to come, and great, come on, line up. And Tom Kotke, right, you're there first, so you get to speak first. Sounds on? Like you're on.
Is on? So, George, you opened the bidding on well-being, and Evans and Stoddard back in 1980 observed that people seek more than health; they seek well-being. And whether you're on the border or you're in Minneapolis and you have skin that's several shades darker than mine, should you really have to become ill from your anxiety about the police or the INS? And if you live in a rural community and your kids would like to come back, but they haven't finished having their families, and there's no obstetrical services, so you have this forced separation from your family, So I would suggest, and Gary Gunderson's over there, and he talks about the leading causes of life. I would suggest that we ought to be talking about the social determinants of well-being. And so we can talk about that after dinner.
All right. Thanks. Thank you very much. George?
Coming here from California, I really have to remind myself that, and not only for out of respect, but out of humility, that we can't presume to have all of the answers for Alabama or New Mexico or other places, because places are unique. So with all due respect, I can relate what my experience in California is, and I happen to live in a rural area now where there's a hospital on the brink of closure every few months, and it closes and then it opens again. And it reminds me of this comparison to people with a boat who say a boat is a hole in the water that you throw money into. In a hospital, in a way, is sort of like that, a hole in the health system that you throw a lot of money into and have to wonder what the benefits are. When in my particular case, we can go about 20 minutes further and go to a tertiary care center that is a trauma center, a newborn intensive care unit, has hospitalists 24/7, and all the greatest and newest modern technology there is, but this other little rural hospital is still being supported by some in the community to very little advantage. Whereas there is another community in Southern California that allowed their hospital to close and use the facility and the district funds to build a wellness center and have upstream activities with community education and health education and classes for seniors and social networking, and is now one of the healthiest communities in all of California, and there's evidence to show that's the case. And even the county, the old traditional county hospital in LA, has turned itself into a wellness center as well. And so there's something to be said about moving upstream and thinking more forward than in a tertiary care center, kind of like, do we really need all of them? And what the comments that there have been about youth haven't been directly on the point of where we've worked with youth, and I've said this before to the Population Health Roundtable, that in the places where the California Endowment is working in rural communities, Central California, Indian Reservation, and far northern California, our deepest investment is in cultivating capacity among the youth to create social engagement so that they will grow up with skills that will translate into developing the transportation system and developing a healthier, more thriving community, and be able to contribute to the economy by being productive citizens and members of that community. And so they won't necessarily think of leaving the place, but staying in the place and keeping their talent in that particular place. And it's not just with health careers, but it's all careers, and thinking of reinvesting themselves in that place. So the community engagement, the civic engagement, is a critical piece to cultivate at a very early age and to maintain that, as well as education, as well as skill building, so that they can make sure that community thrives in the future and that their talent is there. That's the future of rural communities. It emanates from how much we're investing in the youth to get to bring that community around to be the thriving place where everybody wants to live.
Thank you very much, George. Ned?
Thanks, George. I have 2 points. First of all, I just have to talk about how humbled I am by the knowledge, ability, experience, and passion of people in the room. I'm reminded of a theme through the day that I talked to George a little bit about, the phrase intersectionality. So it's bad to be poor. It's even worse to be poor and a person of color. It's even worse to be poor, a person of color, limited educational opportunities, who lives in a rural area, has no access to transportation, or is undocumented. We have to think about the whole person and the intersectionality of inequities as we think about how to address inequity going forward. The second point I'd like to leave with is one of more hope. So there's a movie line, and I'll quiz you later, but I'll paraphrase it as, we are at our very best when things are worst. And I listened to the keynotes really give us data about just how bad things are. And there was a little turn of the screw at the end saying, but that makes us more innovative. And I listened to Margarita and Denisa talk about how one person who's willing to give voice for a bunch of people can make a huge difference at the federal level, and how 2 cents can transform a nation, a tribal nation, into one that's embracing wellness and really thinking about how to change behaviors and take back the food and your health as a people. And I just find that remarkable and inspiring. And the innovation that you folks bring to the table keeps me moving forward. So I'm leaving this conference on rural health equity with a really good feeling about hope for the future. And I thank you for that. Thanks.
Thank you, Ned. I think Margaret Mead was right, so thank you for that observation. Mary?
Thank you, George. And I'm going to reflect something similar to Ned's comments. And I started out with the slide that Dennis put up at the end in the last presentation on the frame-setting factors and added a few to it. I think we did start out the morning with data that painted a picture, but then when you translate that into what's the framing, it was, you know, poverty and the social determinants of health being absolutely critical. Our workforce shortages in rural areas, transportation being a key factor that we have to consider, citizenship status, and I added to that, and racism as a factor. Cultural barriers, and I added history. Coverage, and I said, does not equal access. And then I added access to healthy food being an important factor that resonated throughout the day, as well as access to education, which then in turn can translate into jobs. So that's frame setting, but it's also painting the picture and reflecting on the data we got. But I ended up really thinking most about the incredible voices of the panelists and the people who participated today. The lesson was we have to pay more attention to rural populations. It's 20% of our population and can't be marginalized. Collective action was a huge frame throughout the day, and hope, and a little bit of, I was going to do a play on words with the program called Hope, but also really the hope that I felt from the comprehensive solutions that were lifted up by the speakers. When we talked about high persistent poverty areas, it raised a question for me of what are we doing about trying to get people elected to be governmental reps from those areas. I think there's a whole opportunity. I didn't hear anyone talk about that, but I got a sense that we have a lot of volunteers and a lot of people working in organizations in these high persistent poverty communities. And so I'm wondering whether maybe the next step is to do some training programs and get those community members to feel that they have an opportunity to be elected to government positions as well. It struck me that we had incredibly strong women's voices in talking about the role of women in many of these communities, whether it was taking voice to the tribal council. Denisa, I thought, was really a firebrand in terms of being persistent and being turned down, but continuing to go back. And as Ned said, the 2% tax really had a huge impact. And the tie between economic health and community health, I mentioned earlier on, let's not slip into the trap of falling into this being a healthcare issue, but really taking a look at how an abandoned hospital is a total loss to a community at that time, but it might also open up some other opportunities. And we heard about federally qualified health centers. We heard about how rural clinics, community health workers, and telehealth may be some other solutions that we need to consider. Thanks.
Thank you. I want to go along. Is that okay with you guys? Okay, so we're going to go a few minutes over. And I'm reminded, Mary Pittman, that was Mary Pittman. If you'd all say your names for the record, I would really appreciate it.
Thank you, George. Octavio Martinez. Two comments. The first one was a stakeholder that was touched upon a little bit by Samantha, but we really didn't drill down or talk much about it, which is actually the rural justice system. So what the role plays of our county judges, as especially also our sheriffs and their sheriff's association and the deputies, taken within the context of the opioid crisis that's affecting our country, and also thinking about what happens, especially when there is a mental health crisis and how many resources are taken offline and the impact it's having on them. But also when you take into consideration also juvenile justice, the entire system, and the impact it can have from a health disparities or even definitely a health equity impact, not only at that moment in time, but for years to come. We have a tendency to really think about Harris County, Cook County, LA County as being the largest deliveries, unfortunately, of behavioral health in this time and age. Well, same thing's happening also in our rural jails, but on our smaller scale. So it's something we really need to infuse and remember that they are also part of the stakeholder that we want to include. The second comment started with with Tom's opening and Michael, and goes all the way to the last panel for me, and especially since we sort of bandied about the definition of rurality or what is rural, but it really made me think about, and when I'm thinking about the title of Achieving Rural Health Equity and Well-Being, is how are we defining community? I think that's a really important one, especially I was really struck by what's going along, and I should since I'm from Texas, along the US-Mexico border. And right now, immigrants are not considered part of our community. And so it really lends itself to obviously that fear factor. But they're not the only one, because in my mind I was also making connections, and especially what's been going on in the African American community, and especially the interface with the justice system. Do they feel to be part of that community? And I'm very much strength-based and community-oriented, because I think creativity comes from that. But we need to not fall into the trap of thinking only centrically, but really more holistically.
Thank you very much for that comment. Gary?
So I should not have followed Mary Pittman to the microphone. I tried to beat her here. And Tom took my best line about leading causes of life. I didn't learn a whole lot new today about what was wrong, but I was reminded again of where the hope comes from. And I noticed if you mapped the hopefulness of people, it essentially tracked with those who were closest to the ground and who had not left behind the people that they loved. I'm thinking of Marguerite and Denise and Dale. I appreciated your passion and profound respect for those who you were not only representing but loved to be with. So what I'm curious about is how we would organize what is working in terms of a better pattern among the generative patterns that we're seeing in rural areas, the generative nodes that are coming up in places very close to the ground. And that's sort of a footnote for the future. I think the way to map the rural discussion isn't by what's wrong and what's broken and what's really, really bad and how much worse it's getting, but actually figuring out how do we map the hopeful nodes, the generative nodes that we can build around and invest in and look to the future. I think that's really where I'm going to. And Dale, I need to call your name out one more thing. We're working very closely with the North Carolina Baptists in the deep rural areas of North Carolina, and I suspect we'll have to have a conversation between the Alabama and the North Carolina folks at some point. Thank you for the many presenters today. Appreciate it.
I'm Kathy Bazzi, member of the Population Health Roundtable and board chair of the Michigan Health Improvement Alliance, also working in rural Michigan. So I was inspired and appreciated being here today. I think my comments to be additive start with the overwhelming sense of just the role of poverty that began at the beginning of the day and kept showing up throughout so many times, just how compelling poverty is in terms of a driver and a causative factor of all the challenges. And associated with that was also the fact that it is a system issue, and reinforcing so much of what this roundtable has focused on in terms of it being multi-sector engagement, and the intersects with education, transportation, other equity issues, et cetera, and just continuing to reinforce those themes that we've explored and continue to need our attention. I did appreciate, though, the comment that it's not just a scaled-down version of urban communities, that there are uniquenesses to rural communities, and one of those uniquenesses is the capacity for the citizenry to rise up and give that hope. And we heard so many stories about that. But one of those themes we've encountered over and over is the importance of the engagement of the people, whether that's the youth or the citizens, and that was reinforced so much today. And so I just want to call out those, the level of engagement that's necessary from all sectors, but imploring us to not forget the people as part of that engagement when we're thinking about sectors. And because poverty figures so prominently, I would encourage us to continue to find linkages with those that are doing economic development and community development, and building stronger bridges and alliances with them.
Thank you very much. Right over here.
Yes, I'm Robert McClellan from Dartmouth Hitchcock, and there's a book that was published several years ago called Dumping in Dixie, and it really helps spark the whole environmental justice issue, which we really haven't talked about much today. And so I would just bring that to this conversation in terms of the inequitable distribution of environmental hazards that really do exploit some of what is available in rural America, and that is space, natural resources, and poverty, which then sees sometimes this exploitive dumping, if you will, as an economic opportunity for the location. The other point I want to make is something that I think Businesses for Social Responsibility and Green Healthcare Without Harm has tried to bring home to the healthcare industry, which, as we know now, employs about 20% of the U.S. population. And that is, there's stuff that we can do. I work at Dartmouth Hitchcock in rural New Hampshire, a big academic medical center where there are transportation issues, affordable housing issues, all of the issues that we've talked about today that affects not just them, but us, i.e. our employees. Issues around livable wage and poverty actually affects the healthcare industry, because the healthcare industry does not always pay a livable wage. I know at our organization there are about 10 to 15% of people making less than a livable wage. And so I think we can turn ourselves inwards and look at our own navel as well in terms of being able to address some of these issues.
Thank you for that comment. Very important comment. Martha.
Martha Gold, a member of the Roundtable on Population Health. I keep going back to the wonderful presentations. Every time we have a roundtable, we hear stories from the field that are very inspiring and moving, and I appreciated that a lot today. The notion of taking what we have to make what we need is a very, very powerful statement, and I accept it, except I wonder how one does that to really generate the kinds of resources that clearly are missing in rural areas. Poverty and education are so critical as determinants of health. If you don't have the money coming into your community to build the educational structures you need, then you remain in that particular cycle. And so I think the notion of building, instead of maybe community health workers, community quality of being workers who think in a broader way about what actually produces equity. Health is kind of comes downstream from the equity that we're looking for, and I think the social determinants piece is so clear from what we've heard today. Can people begin to talk about elections and voting at the local level and at the state level? We didn't really talk too much about politics today, but they are the elephant in the room. And until we get better sort of representation for communities of what they need in governance, then many of the resources that need to flow to those communities will be absent. So I really wonder, I left wondering what the level of conversations about politics were in communities and how one examined leadership and how one nurtured leadership that could come and represent people in larger forums so that the resources, which are often financial can keep flowing in that way.
Thank you, Martha. Winston.
Winston Wong from Roundtable on Health Equity. And I was wondering when you said elephant in the room, whether that was a visual pun. But actually, what I took away from today was the history of rural America is really the history of the United States. And there's an aspect of the constancy with regards to how this nation was formed and the struggles and the oppression that occurred, the oppression of Native people and the confiscation of land and slavery. And having said that, I also recognize that it's a living history, and where rural America now is still a changing terrain. And along that theme, I wanted just to point out a couple of things. One is there was, as I think someone mentioned, or there was a question from Melissa, I believe, there's very little mention of the Asian Pacific Islander population in rural America. And it's ironic to me that I'd imagine 100% of this audience has read the book, Spirit Strikes You and You Fall Down, the Fadiman book, which takes place in Merced, California, a very rural part of California, and where the Hmong farmers and a large piece of the Southeast Asian population has settled. This reminds us that this is a changing face of rural America. Similarly, in Arkansas, there is a catchment, I hear, of 10,000 Marshallese that are now the mainstay workforce of the chicken farming industry. And they are facing horrendous health conditions. So as we look towards kind of the historical framework of rural health, it's also important for us to recognize this is a changing demographic and a changing set of dynamics that occurs, and the Asian Pacific Islander element is just a representation of that changing framework of how we look at rural health.
Very, very good point. Right over here.
Margarita Romo. I had two things that I was thinking about. One is that I heard about churches being supportive, but I also feel like there's more that could be done. And I think that one of the things that churches seem to think is that church and state can't mix. But one of the things I feel is very important is that if the church doesn't take the stand in Tallahassee or Washington or wherever your capitals are, and says to that legislator that is passing a bill that is hurtful, who said you could do that? Nobody is really using their voice as a church, I don't think, and I say that because I'm a pastor too. And I go to Tallahassee and I ask those questions and I tell folks, including the governor, let me pray with you for justice and mercy. And I think that we're not doing that as churches, that we're using this excuse of church and state, and that's not what God was talking about. So maybe I shouldn't say this, but I gotta say this, because it's important that if we don't really pay attention to what God says, then we're just blowing smoke. And the other thing is that I just want to thank you for allowing me to come, because I only came by accident because the person that was supposed to come couldn't come. I learned so much, and I feel like for me, it has been a chance to hear that we're not alone in our area of work, that there's others in the struggle, that there's other people having the same struggles we are, and that we really are not alone. And that's important for us to know when it gets really dark sometimes. So thank you so much for allowing us to be here. And the other thing I want to say is if anybody knows or sees a bright star in their community of work, bring them. And I realize that sometimes because of money, I see things come to my desk that it costs a lot of money to go, and I'd love to go because I want to learn, but it costs too much to go. So how are we going to change things if we don't bring the people that need to hear what everyone is saying? And I think that there should be some kind of special way that everybody that is knowledgeable brings somebody who is not as knowledgeable, but wants to learn and has the capacity to learn. Because I know that if it hadn't been for people over my lifespan that had not pulled me along, I would not be standing here today. Thank you.
Well, thank you for coming. Appreciate that. Right over here.
Hi, Tony Viedwell, Center for, where am I? Roundtable for Health Equity and Disparities. So here I
I
am.
had to read that name off when I gave
know.
you thanks. So.
There you go. So again, my thanks to all the panelists for being here and to the audience for being here. I certainly learned a lot about the perspective of rural health here in America. And although we started maybe talking about differences between rural and urban, many of the issues are the same or similar. So, issues of transportation in the city, issues of poor education, we've got that. Issues of lack of access to health care, we have that as well. So again, I think what we need to take a look at is what's the common ground that can lead us to solutions that can address both those issues. I think now more than ever, we're going to have to think about what are those policy solutions that we can address as a nation as we're facing these challenges, period. So we've got to find that common language to be able to talk and forget about the divide between rural and urban, understanding where we're at, but again, coming with a common message. The issue of how we mobilize our communities or how our communities help mobilize us to speak to that, I think is something else we need to think about. And then I think about Kara's comment very early in the morning about how understanding the intersectionality between rural and racial ethnic disparities, I still think it's a little bit of parallel play. I think a little of that came together, and I think that's been a common recurrence in a lot of the roundtable discussions that we have, and we just need to get at the root of some of that.
Great, thank you very much. Mark?
I'm Mark Goravich with the Department of Population Health at NYU School of Medicine and member of the Population Health Roundtable. So much as it's true that there are so many commonalities, I think, that we saw today between urban and rural, I was struck today by the issue of sparseness. And so what am I talking about? We say politics is local, and really in many ways health is local and well-being is local. And we heard many instances, many of them very remarkable, of local initiatives to address health and health inequities and it left me thinking, well, what are the threads that can weave these together, and what is and how can they be scaled? And so, I was left me a little bit hungry for more data on what's working well in terms of the outcomes that we really care so much about in terms of health and equity both. And so the sparseness that is inherent to rural populations makes some of getting that data a little challenging, and it also makes, I think it raises the question of what does it look like to scale in this diffuse sense, and in urban settings that's a little bit different. So those are the questions that really left hanging for me in a way that I think will be interesting to look at going forward.
Thank you, Mark. And I'd just make the observation in closing. Darla Thompson and I and Kathy Bossi were at a meeting in Denver of the business collaborative that our roundtable sponsored. And we heard the fellow from Google talk about the future of work in terms which are very startling in terms of the numbers of things that can be automated, in terms of the impact, in terms of current jobs, and so forth. He estimated, I think, that 70%, if I'm recalling correctly, of current jobs could be ultimately displaced by technology, was one of his statements. I also think about the fact that a lot of things about urbanization and rural, kind of the nature of being rural, are products of the last several social revolutions, the Industrial Revolution and so forth. And we're in the midst of another revolution, that information kind of technology kind of revolution going on right now, which affects that issue around jobs. And it also probably creates a lot of opportunity to overcome some of the traditional challenges of rural sparsity, to use Mark's observation, as well as creates new problems. Every kind of transformation creates new problems. So I think we really need to be sharp in terms of our thinking, in terms of the way forward on some of this rural health issue, because I think the challenges that are just around the corner will call upon us in even more compelling ways to think about this issue of disparity and equity across geography, as well as across race and economic status. I hope this conversation prepares us in some important ways for that challenge going forward. I would like to thank my co-chair, Sandy Magnan, again, and the leadership of the Roundtable on Equity and so forth that I can't remember the full name of without looking at it. But I think this collaboration has been very, very important in terms of the quality of this conversation, some of the ideas, and hopefully some of the effort that will follow going forward. So thank you all for being here, and we're adjourned a little late, but I hope you'll tolerate that from me. So thank you very much.